for a number of reasons, and we've done it consistent throughout the program where we've made changes around this. We want to promote folks to move to more recent standards because we think they are of higher value. We want to be consistent and align with DSRIP and where DSRIP is going. We want to be actively looking at our own data about the value that we see in just paying incentive dollars. We understand that people want that money. We view that our investment in primary care is an important thing. I think we've demonstrated our commitment to that. But at the same time, we're challenged to look at the data that we have that says that this investment, which is accumulated to a large investment, has made a difference relative to return on investment. And it's important for us as a payer, as it is for private payers and for Medicare, to evolve our programs to ensure that what's actually happening is not a paper exercise, that folks are looking at data, and that we're doing all three parts of the triple aim: improving quality, improving health, and reducing costs. So that's the backdrop of our changes, but I'd be happy to talk to you afterwards about the logistics and what you're hearing from NCQA, because it's a little bit different from what I've been hearing.
Tom Campbell from the University of Rochester. I'm a huge fan of DSRIP. I think this is terrific for primary care. It's what we need. The faster we can move from fee-for-service to value-based care, the better it'll be for us. But I'm also extremely concerned about the primary care workforce that's needed to make this happen. So you quoted 1,000 new. This is a net gain, right? Not just you got to replace the retiring primary care docs and add another 1,000. And I'm involved with our workforce committee for our PPS, and I have absolutely no idea how we're going to do this. I'm just curious to the group of the people, since we represent primary care educators, how many residency programs are planning to expand the number of primary care trainees in order to meet DSRIP's needs? Well, they're not coming from this room, but so I'm wondering, I really need ideas. What are the thoughts from New York State and the DSRIP office about how can New York State as a whole or individual PPSs address this issue for this need to expand primary care physicians?
I think these are active discussions. I mean, you know, the numbers here that were provided through the PPS applications, I think people were kind of, you know, putting their pen to paper. We know that they need to revisit these numbers. We know that there needs to be some sort of more, you know, a lot of the DSRIP dollars really actually had to do again with thinking about the workforce as far as the impact of reduced inpatient capacity and the workforce that would be affected, you know, as far as I think the one measurement is for every bed closure, that impacts 5 staff people. So thinking about that, how do you transition them over to a new role? But, you know, when you talk about the clinical side, I think that is absolutely a challenge. And, you know, I would kind of look to, you know, this has got to be our internal work group as far as looking at, you know, SHIP. And so the SHIP and DSRIP kind of, you know, workforce, I think discussions are combining together. DSRIP's been a little bit more focused on, again, the retraining transition. I think in terms of provider capacity, that's a whole collective discussion we've got to have. But no, when these numbers came in, it was like, how is this going to be achieved? Sorry, I don't have an answer. It's just that we are absolutely, it's totally on the radar screen about what do we do. And, you know, I mean, the things that, again, that can be done, you know, everybody's looking again to navigators and you know, and community health workers, how they can expand the primary care team capacity. But those are still small. I understood. So again, we understand the question and the magnitude of it for sure.
Peggy, Lynn Quintos. There are 502, if I'm accurate, hospitals who were not approved by CMS as safety net designated hospital. Some of us are in this room with a wide primary care base population of Medicaid, and we provide vital access to maternal child. It seems to me that when you look at the overall PPS project plan, there's a disproportionate number of projects devoted to perinatal and child care. but there is a lot of children on Medicaid. How do we address the gap, and for a program like us with a growing primary care base, with an intention to advance family medicine training, how do we negotiate it, and what is your advice?
Well, you're right, in terms of the PPS or the district projects, I mean, there was like one or two that were, I think there was a maternity and pediatric care one.
There's one perinatal and there's one women's, infant, and children, but when you look at the project menu, maybe 4 PPS chose those projects.
And, well, I think so much of this was weighted towards the adults
High-paying
because of the avoidable costs and everything else. So for those PPSs who chose those projects, I know that there's going to be, the Office of Public Health will be working more closely with those PPSs on those projects. I think, in terms of the whole, what you were talking about in terms of pediatric safety net, right, we talked earlier about how while your particular clinic may be safety net unto itself, but because you're part of a larger institution where the overall safety net mix does not meet the 35% threshold, CMS would not grant the VAP exception, for the institution as a safety net. There's not much we can do. I mean, those are the CMS terms. The only things I can think of is, is again, your participation in the upcoming Children's Health Home.
Because in New York, we're all children's hospital within a general hospital. I mean, we're not freestanding children's hospital. So Texas was a little bit different. We spoke to our colleague in Texas from Children's Hospital Association. They're freestanding and they're leading their own collaborative for children.
Yeah, we learned, I think CMS learned a lot about Texas, and we didn't go that way. So, done? Okay.
Thank you so much, Peggy.